Hey everyone, welcome back to CGM Sweet Talk with us, the Sugar Queens. This is episode 5 of season 2. I'm Dr. Eden Miller. I'm an osteopathic board certified family practitioner and a diabetologist and obesity medicine specialist from Bend, Oregon. My queen, Jen.
Hi, I'm Jennifer Goldman. I am a pharmacist for the last 35 years. I'm a professor at Mass College of Pharmacy, and I direct the cardiometabolic program at Well Life Medical in Peabody, Massachusetts.
And Queen Davida.
Hi, I'm Davida. I am a certified nurse practitioner. I practice at Henry Ford Health in Detroit, Michigan, and I am into my 44th year doing clinical research and practice. But today I'm up in Harbor Springs, Michigan.
Oh, lovely. Queens, today's episode is a good one. It's CGM and lifestyle intervention. For the next 25 minutes, we're going to discuss how CGM, including utilizing those OTC models, because it can be for lifestyle as well, can help empower those people with and without diabetes. So please drop your questions. You know we're monitoring the chat. We want this to be so valuable for you. Okay, let's get started. Jen, you have a really cool case. Will you tee us off? Tell us about your patient.
Yes, so this is Richard. He goes by Rick. I am old school. I've always called him Mr. by his last name, but I've been taking care of him for about 4 years, 67 years old. I hadn't seen him for a while. So leading up to the visit with me, it turns out he was in and out of the hospital with a flutter. He was cardioverted. He ended up with an aortic valve replacement. So after the hospital discharge, he came in to see our lovely nurse practitioner, Christina, for his hospital follow-up. So during that appointment, she gave me a call because his A1C was 10.9, random blood sugar 306, and he reported to her at that time that he was taking metformin 2 grams a day, EMPA 25 milligrams, tirzepatide 10 milligrams weekly, and that's what I had him on. But he admitted to her that he sometimes forgot to take his medications, and that's something over the last 4 years that we also saw, but never had an A1C this high. So not remembering, he wasn't checking his blood sugars, and he wasn't on CGM. I did not have him on CGM because he was not on insulin, wasn't covered on his Medicare, and cost was an issue. So in my conversation with her, I asked her to initiate insulin. We discussed it and put a sensor on him. We had some samples, and because he had Medicare, now he'll be able to get the sensor. And of course, she's wonderful, talked to him about food choices and how important it is to not miss his medicine. He was agreeable to starting insulin. So she started on 10 units with, directions to titrate 2 units every 3 days and be seen in 2 weeks. So just in case he decided to suddenly take his medications, that's why I started, kind of low on him with insulin, because if he suddenly starts taking medicine, I didn't want him to be too low. Had her prescribe some ready-to-use glucagon as well. So knowing he's going to be back in 2 weeks. So let's look at the next slide. This is what happened in 2 weeks. Take a look at this, Queens, and everybody listening. So before this appointment, Christina and I looked at this before he came back, and CGM having remote access, certainly important, but what you're looking at is 100% is very high or high, 95% over 250, but look at that AGP. When you look at that top line, that's 350. His blood sugars are above that. His GMI is 11.6. So, you can't make people take their meds. We can provide information. We can educate them. So I told her, tell him I'm worried about him. We don't want to be threatening in any way. We're worried about you, and provide education. And I did ask her to do a dexamethasone suppression test, by the way, just in case. So if you look at the next slide, some of the things he told her during this visit was, I know my numbers are off the chart. I know if I don't get my diabetes under control, it'll kill me. He reported that he was injecting 18 units every few days. He said, I was hoping the insulin would take care of it. He also told her with the sensor, always over 250. And the other thing that's important that he told her was, I'm not taking my metformin because of GI side effects.
Oh.
So new important information. So, she reiterated how important it was. She gave me a call during this visit and said, what should I do? And I said, well, double his insulin to 36 units and increases tirzepatide to 12.5 and tell him we're worried about him, we care about him. And, you can't make people do things. So on the next slide, this is what happened. So he came back in a month to see me. So take a look at this. He went from 0% time in range with 95% above 250 to 67% time in range and only 3% above 250. So I was so happy that I didn't even ask him about his meds. I pulled everything open and showed him and said, this is what I said to him. How did you do this? And he looked me straight in the eye and pointed with his finger to his sensor and said, this keeps me accountable. So he went on to explain to me about some dietary changes and that it has helped him take his medications. So at this point, he's on tirzepatide 12.5, EMPA 25, and he's on 76 units of Degludec. So remember, type 2 diabetes, insulin resistance throughout that lifetime, metformin is so critical. So I said to him, would you be willing to try the metformin again? We'll do a lower dose. He was. So I gave him 500 milligrams once a day of the extended release. And after 1 week, let's go to 2. If your stomach is okay, if you don't have GI side effects. And I told him I'll be spying on you remotely. And by the way, his DST test was negative. So metformin can have a very robust response. So 2 weeks later, let's take a look at the next slide. It was a Sunday. And I said, let me spy on him and see what's going on. So I spied on him. And what I'm showing you here is only the second week, which has the 1,000 milligrams for 1 week. And he's 88% in range now with 0% high lows, GMI of 6.9, literally the best response ever in 4 years that I've seen him. I was so, happy for him that I called him on a Sunday to congratulate him and talk to him a little bit about that. And during that conversation, he told me about the impact that had made on being able to have lifestyle changes and hold him accountable for his meds. So let's look at the next slide.
Wow.
I just want to stop for a second because you said something, Jen, that I want to kind of bring top of line because, we talk about lifestyle and the effects of CGM. That's where it illuminates. But when you get CGM, you also get that engagement and you get that, even though I've actually had some clinicians say, I don't want to put them on a CGM because their blood sugars are too high above the thing. And I said, but a lot of times what that does is that shows them. And then what they start to see is an immediate effect in how they live and how they, walk and move. And they come back to us saying, oh my gosh, I really wasn't seeing the effects of the engagement of the medications. So what an amazing case. Davida, what are your thoughts on this? Like when you review this?
So a couple of things. I thought not only does it get the patient engaged, but as a healthcare provider, it gives me the information I need to know so that I can ask more questions. I mean, it was the ability for Jen to talk to the patient and say, hey, what's going on? And the patient feeling comfortable enough with that relationship to say, hey, I'm not taking my medicine. I don't want to take my medicine, but I don't want to die. And so she gave him so many opportunities to improve his outcome. And while he wore the CGM, he got the immediate feedback, which gave him the energy to do it. And so, there's a study on the risk of cardiovascular disease and how CGM lowers that risk. And the outcome was twofold. One was because the patient could see, so they took their medications, they ate better, and they were more active. But then on the healthcare provider side, they were ordering more medications like GLP-1s, GIPs, like Jen did, to give the patient a better outcome. So I love that she got information and she could act on it, and the patient made so many amazing changes in his life.
Well, the other thing too is so many times our colleagues will look at the A1C, and can you imagine if we didn't use CGM on him? I could see an HCP going, oh, well, you're going to just have to add this med and mealtime insulin and this. And you know what? The patient is going to become less engaged. But
Yep.
what you did, Jen, is you met him where he's at, because you, as the clinician, was like, here are your meds. This is what we're doing. But we
Right.
got to check if you're doing your part, and not in terms of a shame or blame, but an awareness, right? It's like he needed to catch up to his current treatment. Yes, you augmented it, but there's no way that that insulin filled in all the gaps. No. And in fact, as he's probably going throughout his usage, he's probably even de-intensified the insulin at times too,
Yes,
you know?
I did forget to mention that when I added the metformin back, I decreased his insulin by 20 units because I knew that he was going to have impact. I knew he would, I knew that was going to happen. And if we think back to the 4 years I've been seeing him with this difficulty, this is what's missing.
Yeah.
Is data for him. Having that power, he can able to take care of himself because data is everything.
Well, he gets that feedback so immediately. And some of our colleagues say, oh, I don't want a CGM for a patient because they're going to feel bad. No, it's really kind of that he's like, oh my gosh. And the other thing too is when you use CGM, you can have immediate impacts, and that's so empowering. You could teach them in 24 hours.
And I think sometimes the healthcare providers hide behind the A1C. And what I mean, they do. So they see an A1C of 11.7. Oh, that patient.
Oh, it's the patient.
It's the patient. They're non-compliant. They're not going to do anything. And I can't teach them anything.
Well said.
And for the patient, they're feeling helpless and hopeless because they see the A1C and they're not getting the kind of support that Jen and this healthcare provider came up with. And so now he can own his own diabetes and move it forward and get out from behind that A1C.
Exactly. And Jen, is he still, because sometimes I hear clinicians say, oh, I'm just going to put it on one time and then they'll look at their lifestyle. But he's been using it ongoing, right?
He has, and I was able to prescribe it with DME. So now it's covered. So that's not a barrier anymore for him.
Yeah, that's
amazing.
Davida, in your practice, I mean, I use CGM in kind of my own special way. I'll be honest with you too, even though you chose a great case that is somebody on insulin that could be covered. So we've really removed all the barriers. But, I actually use continuous glucose monitoring for individuals in the pre-diabetes or early diabetes state because it is a lifestyle type of thing. And so I want every one of our listeners to stay tuned because the other Dr. Miller and I and Richard Bergenstall next year are going to have a bunch of data coming out about lifestyle effects and using CGM in pre-diabetes. So stay tuned because we're going to see a lot of it. But Davida, let's look at your practice a little bit. Tell me how you're incorporating CGM for those lifestyle changes. What are you doing?
Well, absolutely. We don't care what therapy you're on. We absolutely want you to have an opportunity to wear CGM. And we do believe, so it isn't just insulin. And I'm going to have to say it, it's a right, not a privilege. Everybody should have the opportunity for CGM. And I think the healthcare providers need to move out of the way and give it to our patients. So within our own practice, if you come in, you have diabetes, we're going to offer you CGM. And the other thing is not every insurance company will pay for it if people aren't on at least one injection of insulin, but many of them will. And the other thing to keep in mind is that a lot of times for the benefit of CGM, patients will pay out of pocket. So everybody gets to spend their money the way they want, and we should remember that as well. So ADA standards of care are now saying people with type 2 diabetes as well as type 1 diabetes should in fact be offered continuous glucose monitoring. And then this is some American College of Lifestyle Medicine, and they talk about the importance of intervening for things like social connective sleeps, other management. And we know that if I give nutrition, a physical activity, if I give a CGM to a person with diabetes and they can see what's happening, they're more apt to continue to wear it and make lifestyle changes. Absolutely.
Another thing that I'm having in my area, and I'm sure because we all span the coast to coast, is I am actually having my CDCESs really understand the value of continuous glucose monitoring. And so when I refer them to CDCES or dietitian, they actually utilize that data in a very kind of focused way to really kind of do almost a nutrition kind of prescription. And I'm sure you guys are having that as well.
I think the number one change in nutrition is wearing a CGM. So if you wear a CGM, I did this thing. Well, I did it with you, Eden, a couple of weeks ago, where we wore sensors. We already wear one. But I got to wear a sensor. And I was like, I'm thinking, my glucoses are just hunky dory, right? Well, every time I ate dessert at dinner, I'm like, whoa, look at what happened. Maybe I only needed half of the dessert. And I have to tell you, for breakfast the next day, I picked different foods because I didn't want to see those numbers going up. And that's true for our patients as well. And I also know that when they're physically active, because patients will say to me, my blood sugars are a little bit high. Gee, I don't want to take more medication. I'm going to go walk around the block. So
Isn't that lovely? Empowerment
of changes in their life. And for stress and things of that nature, I think it just helps them, again, own their own diabetes. They're making good decisions. Diabetes is a full-time job. We all know that. But if you wear a sensor, it takes away some of that stress and some of that burden for people with diabetes. So I think that's other things. Go ahead.
One of the things that I like to approach it, because, sometimes we can look at all those pillars that we were talking about, the stress, the physical activity, the lifestyle. So I tend to focus on maybe one or two. I'll ask the person, what would you like to focus on next? What's kind of some of those things? But I can tell you, as us queens, as we're using this, and we should really have a queens episode based on stress, because I've actually had cases where I had this one gal that I'll never forget. She was doing super good. She was on insulin and GLP-1. She was working on her weight. She was working on lifestyle, and she comes in with her AGP. And all of a sudden, 2 days out of the week, like Tuesday and Wednesday, at 3 o'clock in the morning, her blood sugar was like over 300. And I'm looking at her and kind of teasing her. I'm like, girl, are you raiding the fridge? Like, what's going on, right? And she goes, what? And I said, Tuesday and Wednesdays, you go to the stratosphere, like an aberrant kind of thing. And she goes, oh my gosh, that's the time I watch my mom on hospice. She comes over to the house, and we saw this very concrete signal, right? This very concrete signal where instead of me talking about intensification of medications, I was like, how are you doing? What's going on? What are you worried about? And she says, I'm afraid she's going to fall when she goes to the bathroom. And so I'm using a CGM to talk about bedside commodes so she doesn't have to worry about it. So Jen, weigh in a little bit about how we are seeing the effects of looking at AGP with sleep, because I know we can see things with sleep and different stuff like that. So talk about that a little bit.
And I think those are things that people forget to think about is sleep, social connections, and risky substances. So poor or irregular sleep can actually increase insulin resistance, raise appetite, make blood sugars more difficult to manage. So if we think about when you're sleeping at night, patients might be at risk of nocturnal hypoglycemia, could be unnoticed if you're not wearing a CGM. And on the flip side, dawn phenomenon, where blood sugar rises in the morning, we have that cortisol, that growth hormone. So that CGM can help. Is also obstructive sleep apnea, and that causes that intermittent drops in oxygen, a surge of stress hormone. So then you can end up with worse insulin resistance. So that whole loop there, CGM can uncover that as hidden, right? Yeah. So we got to remember that. And then, social connectiveness, that is also forgotten because, like you just said about stress, social connectiveness has a huge role in diabetes management. It's underestimated. So people who feel isolated, they have lack of social support, they have more stress, they have more depression, they have low adherence to their medications, or so things like that. And we know then there's data to support that having a supportive relationship is linked with better diabetes management. So being able to share your data with your your mom, or being able to share it with your family members, with being linked that way, caregivers, healthcare providers, allows you to maybe be less fearful of a serious low or a high, alerts. All of those things can really help people. And the thing about risky substances, oftentimes what comes to mind for me is alcohol, but alcohol, nicotine, recreational drugs, people don't realize the effect it can have on blood sugar. So hypoglycemia, often delayed, often occurring overnight with alcohol. So people forget that, and that can be certainly disruptive. And nicotine, stimulants, increased insulin resistance, increased cardiovascular risk, certainly cannabis, steroids, all can increase weight, increase appetite, increase blood sugar. So having real-time data with CGM can be powerful. And certainly we just saw a patient with it influencing lifestyle in terms of dietary changes and adherence to medications. But in this case, being able to see the impact of these substances may influence the choices of using these substances and have behavioral change.
You can see that CGM is an individual map of all the places a person goes with their glucose and all the factors that affect it. That's what's so good about it. Yes, we can generalize it, but it is so individualized, and there's so many different layers to unpack. Davida, talk to us a little bit about the research that supports this. Don't just take our word for it, but talk about the research.
Well, these are 4 very interesting and a little bit different studies. And the first one, the author is Martins. I actually was an investigator and one of the authors on that paper. And over 6 months, what we did was we used individuals with type 2 diabetes, and we were looking at nutritional changes and how that would affect their outcome with CGM. So we asked them for the first 3 months of the study not to change any medications, but to look at the CGM data as well as what they're eating. And in fact, we saw better A1Cs, less hypoglycemia, and weight reduction during that study. And that's on non-insulin individuals with type 2 diabetes and using of CGM. The second study was Tom Grace's study. And he always makes me laugh when I think about how he did this one, because he's a diabetologist. He also has diabetes. And he up and decided that his little town in Ohio, everyone who had diabetes was going to wear a CGM. He and I think a lot alike. And he got the town somehow to pay for CGM. And his goal was to give it to all comers and not change their medication. We want you to wear this. And he showed 3-month data where A1Cs that were very high came down over 2% with just the introduction of CGM. Now, some of them were on insulin, some of them were not, but he had great outcomes. And then the real world data study was was educational and transformable with those individuals. And 70% of them said that they had a better understanding of their daily activities and their diet, and versus only 16% were seeing a difference if they were doing finger sticks. And then finally, this was a systematic meta-analysis of over 25 studies. And people had to be in the study for using CGM for a certain amount of time. It was obviously data reviewed, retrospective. But they were looking at A1Cs, weight, hypoglycemia, hospital admissions, illnesses, and cost. And there was a positive outcome every time they looked at individuals who were using CGM, and they were not necessarily on insulin, but they did have type 2 diabetes. So all 4 of these studies, real world and randomly controlled trials, showed us that there's a difference, and that you don't have to have type 1 diabetes, folks. Type 2 diabetes, and you don't have to be on insulin, because lifestyle modifications are where it's at with the use of CGM.
Well, ladies, I think we have made such a good case based on the one that we reviewed, the research. We see how it's individualized and they all can have those lifestyle effects. But I want to change gears for a minute because we talk about coverage and acquisition. And so some people don't have current coverage, even though we know the standards of care says you got diabetes, you qualify. But the reality is, give us a little bit of suggestions of what you do, Jen, to try to acquire CGM or get it covered or get it in the hands of the person.
So for most people with commercial insurance, with or without insulin, it's covered for most, but not all. And Medicare, again, you have to be injecting, or you have to have some other issue where you can do a prior auth where, you can't use your fingers, there's something else, you've had hypoglycemia. So I'll go that route, do a prior authorization, try to get it. If they can't still get it out of pocket, there's a coupon available which brings, a 30-day supply to $75. But for example, for the patient, I talked about with Richard, is that was not affordable. So, I can have samples. Not everyone can have samples. So sometimes intermittent use and using, a sample, put this on before you see me, that might help. Or if somebody is paying out of pocket, to save it for before the visits or when you make med changes. And now, we have over-the-counter CGM available. So, that is certainly an option for patients, but that, again, that's not covered by insurance. And there is some differences there for sure. So the over-the-counter, there's no alerts. Where the prescription there is. And in terms of targeting prescription, with people with diabetes is, not that we can't choose to use it differently, but the target users for over-the-counter would be people pre-diabetes, that they could have diabetes without insulin or no diabetes. One of the biggest differences is the prescription CGMs, that they are integrated with insulin pumps and with the electronic medical record, having to be able to have that data. But you don't need a prescription. So that does for the over-the-counter. So it does open access to everyone. So even if cost-wise, a prescription one might be affordable, you still need to get a prescription for it.
Yeah. And I think you're right in terms of kind of choosing where the person's at, because there are always barriers in medicine, and a script can be a barrier. And so when you don't need a script, you're removing a barrier. But it can also be that the prescription is actually cheaper, and even in the cash pay scenario. So I don't want us to neglect that as well, that even if you have a diagnosis of diabetes or you think as a clinician you qualify, go ahead and send the script. Don't be the barrier. What can it hurt to do it? I think I hear that a lot of providers saying, they don't need one. You know what? If you don't want to do CGM, fine, but don't be in the way. You know what I mean? Don't get in the way.
And the other thing too is that if you send a prescription and they get prices, they can then price shop too. So I'll tell my patients, even before I send the prescription, call around. And, sometimes in your own area who has the best prices because other patients have told you, so I'll say, call so-and-so or call so-and-so and see what their prices are if you don't have coverage. And then they can make a decision between over the counter or not over the counter, and give a prescription for those. Because as Jen said, there are some decent prices with coupons if you don't have insurance that covers them. So it depends on the need of the patient. Sometimes I want them to have alarms. So if they have no coverage, I want them to see if they can afford cash pay and shop around.
So Davida, walk us through very quickly the OTC, and then we're going to try and wrap it up and see if there's anything else we missed.
Well, I think there are two main OTCs that we're familiar with. They're coming at us, but Stelo by Dexcom and Lingo by Abbott. The big difference is that Lingo is really lifestyle changes. Stelo's for diabetes, pre-diabetes, and type 2 without insulin. But again, we can mix that up as healthcare providers. And none of them have alarms, but Dexcom Stelo can be uploaded into the places we already look at data. So I find that to be helpful as well. But both of them, there are no readers. It has to be on your phone, and they're cash prices, 15 days. So they're very nice, and patients should investigate them if in fact they don't have coverage.
You know, to wrap things up, Curtis Carter, our longtime listener, who put a question in the chat, and, you know, he's talking about the fact that we don't have certain parameters yet for over-the-counter or, you know what, stay tuned. I promise you, coming in the first quarter of next year, we will be having some of those parameters and what normal glucose is. Ladies, we packed it in today. We packed it in. Jen, Davida, thank you so much for discussing lifestyle. We want to make sure that you can claim that CGM, that credit for our CME for CGM. I love it. Our CE and CME credit for CGM. Don't forget that we have ongoing Sugar Queens episodes, and you can see a lot of our archives. So please tune in next time. Bookmark your season 2. We're so happy to see you, and we want to thank you for joining us Queens today. Have a great day.
Tell them we have a guest next month too.
Oh, Ann Peters, our guest. Yay! Yes.
And we're going to be live.
Live.
Together.
Together, yes.